In the Brainwell program, it is genetics. We focus on genetic testing, mostly on pharmacodynamic. That means the body's ability to make things such as the L-methylfolate, body's ability to how they metabolize things, and the body's ability how to make BDNF. Not so much in the pharmacokinetics. I mean, that's pretty much a given. The thing we have to remember is you can look at all the pharmacokinetics and what meds to give, what not to give. But if you're not considering the pharmacodynamics, you're actually going to make the patient worse sometimes because you're giving them things that are not really the best for them. Okay. So like an example, somebody who's MTHFR deficient with low COMT, what does that mean? Somebody who can't make serotonin, dopamine, nor epinephrine, right? But the little dopamine they have around, it stays around, right? It doesn't go away. So this was the reason why I started seeing patients that, oh, you have MTHR deficiency, take your L-methylfolate, and they come back 2 weeks later, I'm anxious. And I didn't understand that, but because I didn't look at their COMT metabolism. What you've done is you fueled the fire. So in these cases, sometimes it does make them more anxious, sometimes it doesn't. So I warned the patient. I said, okay, we'll give you a lower dose of it, but if you start to get anxious, then you just don't take it. And I have other ways to increase tryptophan and serotonin without increasing the dopamine. And that's another lecture too as well. And we can, there's ways to go around it in order to decrease their anxiety by helping them build their serotonin without worsening their dopamine level. Okay, so that guides the rest of your treatment. This actually will guide your ability to say what kind of sex hormone treatment that they're going to get. I've had a situation where I didn't know the patient was low COMT and I was giving him testosterone or things to stimulate it, and he got really anxious, and I redid the test because it didn't have it the first time around. And I was like, oh, like with the testosterone, because he was like brain injury and he was depressed and sitting at home and not doing anything, increased the testosterone. Yeah, he felt good, the first, second month, third month. So I'm getting anxious. And I finally was able to look back and say, okay, we repeated the labs. Estradiol was so high. So we had to bring that down, minimize the body's ability to make the testosterone, but still try to bring it all balance. Anxiety went down. So lots of things you can learn just by looking at somebody's genetics and how it can dictate the rest of your treatment. And of course, genetics, if you don't look at somebody's genetics and you start giving them things that, so we talked about with L-methylfolate and they have low COMT, you're going to have a bad outcome. But if you know that already, then you can be more careful. You can watch it. The genetics and the right kind of supplements will help somebody to respond to TMS better than the average numbers. Okay. And you will have longer response to it. And of course, if the patient is not doing well with TMS and supplements and genetics, we're not missing the piece of the puzzle that, hey, what if they are hormonal deficient? What if they are low progesterone, low pregnenolone, low testosterone, and they're having difficulty losing weight despite of their eating right and their exercising right? What if they have a deficiency in their growth hormones, as well as what if they're having problems with insulin resistance? So doing those things, lifestyle measures, we can still make those recommendations. But however, if we don't know what we're dealing with, we don't know the direction we're going to. But doing all these things and knowing how they do connect, because no one taught me that. I had to figure it out and bang my head. Oh, learning this. Oh, this is how it happens. And now we have a safer method in how we can get our patient better, right? Okay. All right. Before I talk about any other cases, is there any questions at all? Like anything at all?
I do have a question.
Okay.
When you mentioned low content,
Mhm.
you're talking about med.
Yes. Yes. Yeah. Met. And then I would say just when I learned all what I needed to know about CompT, low or high, I started looking back at all my patients and I said, 80% of my psych patients are either high or low. And it starts from there. And the good news is, if you know that, like, okay, somebody who comes to you for ADHD and they have Val, was what you see in the genetic testing, you can give them lifestyle measures to help create their own dopamine. They don't have to be loaded up with Adderall, or because that's impossible to find right now. And so maybe they won't need as much of a stimulant. If you tell them high protein, you got to exercise, take this supplement that increases dopamine. Okay. All right. And then, of course, when they're like the opposite, low protein, relaxation exercises, things that will elevate their serotonin naturally without elevating dopamine. And can a person with MET have ADHD? Yes, it can happen because they still meet criteria, because they can't focus, concentrate, and all that. But it's because they have way too much dopamine. They're so anxious, they can't think right. So that's why, in theory, medications like the Intuitive works better for them, because it brings down the hyperness that's coming from the dopamine, too much of it, and it tempers that. And that's why Intuitive works for some people for ADHD. It doesn't do anything for people who have high CompT, because you're just blocking something that they already lack. So you're already now putting the science into clinical practice and telling people, and I've had really good results with patients who have had ADHD, and I was giving them a bunch of stimulants and they were like low CompT. And then, of course, with this whole Adderall shortage, they were finally open to suggesting, hey, try some Intuitive, and they realized that worked without worrying about going in a shortage. So it actually even works pretty quickly compared to like what you think it would not do, but it does. So, but of course you have to educate the patients, like, listen, too much dopamine in you, that's why you can't focus and concentrate, you're anxious. So we need to tamper that effect. So, all right, anything else? Any other questions? Okay, all right, thank you everyone for coming. Next one will be when?
March 24th.
Okay, March 24th, same time, same bat channel. But this time I will really get into genetic testing and really I'll even talk about what are more clinical things we can do. I talked a little bit about today, but not the way we're going to delve into it even better. All right, bye now.